Salam. Today we will talk about the cracks and fractures. We will discuss the three types that are only in the crown fractures or the split tooth that the tooth becomes two parts, separate one, and the famous vertical root fractures. It is a bit challenging to diagnose these types of complications because it is not as obvious as a caries lesion. Patient may undergo several months of having pain, and the dentist is not able to locate its location. So both of them would be frustrated. And the result is that the patient loses the trust and confidence in his dentist. So early diagnosis is essential to get the proper treatment. The cracked cusp first is that when the crack does not involve the pulp, it is only in the crown area, and we can diagnose it by the patient suffers from pain with chewing, not able to chew on the side where which the crack has occurred. Long period of time, the dentist is not able to find the source. There is a sharp pain immediately that stops him from continue the chewing and the masticatory process. The tooth is vital, and we are having a reversible pulpitis. Often of the times, the tooth has a wide restoration, and sometimes we can get these cracks even if the tooth is sound and there is no any restoration in it. We do the diagnosis using the bite test, using this sloth device that is pyramidal, which means that the patient perform the mastication in on each cusp by its own, rather on the whole tooth, which makes it differential diagnosis between the periodontitis when the pain is on the whole tooth and the whole cusps. But if we are getting pain on specific cusps only, that means that there is the crack, the crown crack. The patient will typically state that this sensation has reproduced the sensation of their chief complaint. So this aids us that we are in the right direction. We can do what is called transillumination, which means that we use a light and see the line of the cracked cut. Sometimes we need to remove this large restoration to know the extent of the crack presence and determine the appropriate restoration possible. If it's not, it did not reach the pulp chamber, we can do a full crown, and we must tell the patient about the prognosis of the tooth, that it may develop to an irreversible pulpitis. For example, here, the mesopalatal cusp was fractured, so we removed it and we did a root canal treatment and covered the whole tooth with a full crown. We do the endo treatment where there is signs and symptoms of pulp pathosis. Now let's discuss the split tooth, where the two segments of the tooth become separated longitudinally. There is a sharp pain upon mastication, and the dentist is unable to diagnose the source of the pain. The patient may say that at first there was a sharp pain over mastication, then they have developed a sensitivity to cold stimuli. Then at a later stage, the pain has subsided, and this means that the pulp has become, at first it was pulpitis, then it became necrotic. Due to this split tooth or the crack that is happening, it begins with the crack. It begins coronally, and it extends to the apical part. And this is important differentiation between the split tooth and the vertical root fracture that we will see later on. Usually, the split tooth is in the buccal-lingual direction. We rarely find it in the mesio-lingual, in the mesio-lateral direction. This is also an important thing, that we cannot see any radiographic manifestations, and this is a differentiation between the vertical root fracture also. The split tooth has poor prognosis from the cracked tooth that we discussed earlier, especially if this crack resulted in a pulp necrosis. Then the prognosis is actually poor. Even though we can see here that the restoration was shallow and it was far from the pulp, but we see that the mandibular second molars and the maxillary premolars are the most suspected tooth to get these kinds of incidents. When the split tooth occurs, the resulting parts of the tooth may be movable by using an explorer. We can use the methylene blue dye as a diagnostic procedure. We can also do the anesthetic of the suspected tooth to locate if the tooth is in the mandibular or the maxillary arch. So for the split tooth, we cannot detect it radiographically. It is associated most of the time with a big restoration, and we can see it by translamination, by the dye, by anestheting the tooth, by doing the with the explorer. We can go along the cusp and see if there is any movement, and by taking the chief complaint and the medical history from the patient about the mastication pain that they are experiencing. It starts coronally and develop apically. The etiology is the masticatory forces that are unappropriate forces, like the paroxysm, the occlusal prematurities, and the traumatic injuries, unexpected chewing of hard objects. When we diagnose the split tooth or the cracked tooth, the patient should be informed that the prognosis is reduced. We can do an endo treatment and placement of a permanent crown, but there is a study of 127 cracked tooth with the reversible pulpitis. 20 of them has developed an irreversible pulpitis after 6 months, and some of them they retained sound for a whole 6 years afterward. If the crack reached the pulp chamber, the prognosis is poor. When this cracked tooth developed to a split tooth, which is a complete separation, extraction is our only thing we can do. Now let's talk about the vertical root fracture. It is an incompletely separated root. It has a radiographic signs, and it initiates from the apical root and travels to coronal part. The patient is sensitive to while chewing. The tooth usually had an endo treatment, and it is so rare to get the vertical root fracture in a tooth that did not have an endo treatment. Usually there is a post associated with it, and we might conflict between the need for retreatment and between the vertical root fracture. We will see how we can differentiate now. So there is a sensitivity upon the chewing. We might develop a swell in the mucosa beside the root. Also, a sinus tract may be developed, which they are similar signs to non-healing root canal treatment. As for the radiographic signs, we can see that the vertical root fracture has a single deep, narrow pocket, and there is a loss in the bone around the root, and this is what is called a diagnostic a flap to ensure that this is what we're having is a vertical root fracture. We have the J-shaped halo radiolucency that is associated with the whole root and not confined in the apical area only. The vertical root fracture may result in a split root. When we confirm that we are dealing with vertical root fracture, we must do the extraction as early as possible to prevent any bone loss that will compromise any further and future restoration, whether it is in an implant or an fixed prosthodontics. Which may be required, adding additional costs and time to the restoration process if we needed the bone regeneration procedures. So this is important, a differential diagnosis between vertical root fracture and endodontic failure and the periodontal pocket. How to differentiate between these both is that the periodontal pocket is coronally wider, but the vertical root fracture is a narrow, deep one. The periodontal pocket is associated with the proximal sides of the root, but the vertical root fracture pocket only we can see it in the buccal or the lingual or palatal sides. The presence of typical vertical root fracture pocket is present in 67% of all vertical root fractures cases. We can see here, this was indicated for retreatment, but the vertical root fractures made the tooth irresortable and it was extracted. As we said, we can raise a full thickness flap and facilitate the visualization of the vertical root fracture using the methylene blue dye as a last choice of diagnosis. They are saying that the oval-shaped roots are more suspected to the vertical root fractures more than the round one. We used to say that we will do an endo treatment. We are making the tooth weaker because it loses its hydration and the water content inside. But the reality is that the reason that the tooth becomes weaker is because of the loss of the actual tooth structure due to the access preparation that we are doing, and this is the actual reason that makes the tooth able to get these fractures. Also, using the rotary files enhances the chance of getting micro cracks in the dentin, but the manual files do not do this. Also, the root obturation with lateral compaction and non-surgical endodontic retreatment affects and increases the possibility of getting these cracks. We should prevent using posts the root ones as much as possible because it weakens the tooth. As we said, when the vertical root fracture is diagnosed, rapid extraction is important to get a repair in the future without any loss of the bone. I think that's it. Cusp. Crack between the cusp and the rest of the tooth structure that does not involve the pulp. The clinical signs: pain when chewing. The tooth is vital, often associated with extensive occlusal restoration, may also be present in intact, non-restored teeth. The diagnosis: biting test, illumination. The treatment planning: full coverage crown. Endodontic treatment is indicated only if signs and symptoms of pull pathosis are observed. The fractured cusp. The crack may propagate, eventually resulting in a fractured cusp. When the crack reaches the pulp chamber, the prognosis becomes low. The patient must be informed, and an endo treatment and a full coverage crown is indicated. The split tooth. When fracture occurs that separates the tooth into two parts, the tooth must be extracted. The vertical root fracture. Root is incompletely separated, initiating from the apical root and traveling coronally. It happens in endo-treated teeth, most of the times that have posts inside. The diagnosis: sensitivity and discomfort while chewing. Swelling often occurs and the sinus tract may be present. A deep, narrow, and isolated periodontal pocket. One of the most typical radiographic signs is a J shape or halo radiolucency, raising of a full thickness flap to visualize of the vertical root fracture with aid of the methylene blue dye. The treatment is extracted of the affected tooth is recommended as soon as possible. Any delay may increase the potential for additional periradicular bone loss and potentially compromise the placement of an implant in the future.